As moderator, let me start. I don't know that everybody here knows about the monoclonal antibody PrEP trial. So can you tell us a little bit about that, Michael?
Sure. We're starting this new HIV prevention trial that really is seen to be the key towards an HIV vaccine that will work broadly against strains from around the world. It is a monoclonal antibody really developed over the past 5 years at the laboratories at the NIH, and that's remarkably fast to get from discovery to people within 5 years. What it is an antibody that's active against a really critical place of the virus that's shared between all the viruses around the world. Now, you've heard about a lot of the diversity in the virus, the mutations and all that, and there's a lot of sugar coating of the virus to disguise the virus. But this recognizes that critical part that is required really for infection of CD4 cells. And that was discovered in patients, actually, over a period of time. About 20% of HIV-infected patients develop these broadly neutralizing antibodies. We don't really know exactly why, but a whole series of these things have been discovered and then in the laboratory reproduced, made into monoclonal antibodies. And so the common denominator of these things is that they're really at the critical places that the virus couldn't survive if there was an attack there, if there's an antibody blocking it. It couldn't cause infection. And until we discovered this, and perhaps even the Thai trial in 2007, for a long time we didn't even know for sure if a preventive HIV vaccine would be possible. So this is really exciting news because it's going to be a test of principle. If this works, then it becomes a simple issue of engineering a vaccine to produce this type of antibody, and all resources can go towards that. We wouldn't want to dump all resources into engineering that if it turns out we need to know more, we need to understand more. So again, it is a study, and there's no guaranteed outcomes, but we're very excited about this study that'll begin in probably January. Locally, or in the Americas at least, we're enrolling men who have sex with men and transgender women who have sex with transgender people who have sex with men, and the African part of the trial will be in primarily in heterosexual women. So there's a global trial at 30 different sites, and we're one of them because we've really been one of them since the very beginning.
So, Michael, is this a form of PrEP? Is it like
Truvada? It can be viewed as a form of PrEP, but PrEP in the common usage kind of means Truvada. Technically it doesn't any more than ART or HART means a particular combination of the 3 medicines. It can be viewed as a form of pre-exposure prophylaxis that needs to be given only every 2 months. And really, that's part of where the field is moving from daily PrEP. It works very well if you take it. And you don't even have to be perfect, although we don't tell people that. You should be perfect. But the big problem with anything is remembering to use the condom, remembering to take the medicine, remembering to adhere to the antiretrovirals if you're infected. So essentially, it's all on a continuum of PrEP. A vaccine is like a PrEP where you give 1 shot and you're good forever, to the other extreme where you need to take a pill every day. So the move is really towards longer acting preparations, but that's not to discourage anyone from taking PrEP now. It's a very effective medicine if you take it.
One of the other things I want to add to what Mike said is really this whole vaccine trial wouldn't happen if it wasn't for the community here. We have the greatest rate of participation in clinical trials per capita in the country. That's been the reason that Mike's and Amneris have both stayed in this business, and that's because of all of you in this room. So I do want to really thank you all.
So let me take advantage of the moderator's position again to ask Dr. Gelbard a provocative question. What is neuroAIDS, and why should we be interested in it?
Okay. I actually, curiously enough, I can remember coming back from the charter studies, which were funded by pretty much, it was a split between NINDS and NIMH at the National Institutes of Health. And I was the leader of the advisory council, and an internist in New York said, you know, I take care of patients with HIV all the time, and I don't see any of this HIV-associated neurocognitive disorders. And I said, well, tell me about your patients. And he said, well, they're hedge fund managers, and you know, they're captains of industry. And I said, so if they shave a few IQ points off of their IQs of 160, how exactly would you notice that they were affected? And he said, well, that's a good point. But so let me come back to this and say that I used to call this the disease of 75%. And that is that if the brain is built on redundancy with multiple circuits designed to take over in case a certain region or part of a region's circuitry is affected by the HIV virus, then you can get by pretty well. It's when you start overloading things, whether that be because of the normal trials and tribulations of the aging process, or in the case of HIV, the accelerated aging process that takes place despite antiretroviral therapy, you can start to see things break down. And where you start to see it is in your ability to switch between processing multiple sets of information. We all call that living in the modern world. We make jokes about mild cognitive impairment and not being able to remember things, but if you look for it, it's there in the community, and most people, frankly, as opposed to the stigma of watching someone succumb to HIV-associated dementia, will be the first to tell you that they do have some type of mild cognitive impairment. They'll say yes to all of these things, and they'll say, but I'm alive. And so pretty good gets to be good enough. The problem becomes, as you live long enough, when pretty good won't be good enough. And that's when you really start having to think about it. If you go and look at neurologic disease throughout the world, you still see the same classical, terrible things that happen to the nervous system. So when the charter studies came out, it just confirmed the obvious. The virus was in the brain early. And that eventually 1 out of 2 people were going to have some form of HIV-associated neurocognitive disease. I'll add one other thing, because I'm actually a pediatric neurologist by training. I was the neurologist for the pediatric HIV-associated cohort studies. It's ongoing. It's a 15-site consortium. And if you think that aging is bad, being born with vertical transmission of HIV, or even being exposed to antiretroviral therapy so that you can be born seronegative, that's terrible. The kids that are born with vertically acquired HIV are like a greatly accelerated version of HIV and aging in the adult population.
So what about the confluence of aging and this cognitive disorder associated with HIV? I think by 2020, 70% of people living with HIV in the US are going to be over age 50, which is defined as elderly, I believe.
What were we talking about? Anyway, I'd have to say that there's the other obvious shoe waiting to drop. I mean, all the other comorbidities of aging, classical non-infectious neurodegenerative disease, whether it be Parkinson's disease. It was one of the things that motivated me about studying this disease in the first place. It was some of the first presentations of neurologic manifestations of disease in people in this country. Parkinson's disease, Alzheimer's disease, all those things are there, and they're there as a consequence of accelerated aging. So if having one is not good for you, having two is just going to be terrible.
So accelerated aging in the person with HIV?
Yes.
So what can be done about it?
Well, the work that we started took a very different tack. And this is really a group effort. And on my left is actually the person that I would have to say functioned as my mentor on the ground when I was changing careers and going away from Parkinson's research and becoming a neuro-AIDS researcher. And that's Steve Dewhurst. And he taught me a lot about what the virus had to say for its life cycle, and that it was in the brain early, and that for the people that were already infected, there was no vaccine out there for them. So the question was understanding what was happening between nerve cells and the cells that the virus was infecting, and really getting to what might be an addressable target to intervene with a small molecule therapy, a pill that you could take every day, or perhaps less than that, if you could strike a new balance between inflammation, which is what the virus sets in motion, and once it's set in motion, it's progressive. It doesn't matter that you can successfully control the levels to an undetectable amount. That inflammation persists and is progressive. And the nervous system, which of course bears the brunt of it. And as many people understand, while stem cells hold a great promise for therapy, you can't replace your whole brain. And once the nerve cell dies, that's it. You don't get it back except in some very specialized regions in the brain. What the brain uses are synapses for its unit of currency, its unit of neurologic function, and those are plastic. They're changing constantly. They're changing while you're wondering how long I'm going to talk for. And so they remain plastic. What happens during inflammation is that you lose that plasticity, and you get behind the 8 ball. It's a self-perpetuating phenomena. So we spent the better part of a decade trying to repurpose already FDA-approved medicines that were good. We made incremental progress, and then we finally got tired of doing that and decided to go where we thought the virus was really affecting both the immune system and the nervous system. And we used a lot of other people's expertise to get there, but we realized we were going to have to come up with a brand new class of medicines and identify a target that was shared both by the immune system and the nervous system. And that led us to a series of compounds that I could talk your ears off about. But the bottom line was trying to re-engineer homeostasis, a better relationship between the immune system and the nervous system. As it turned out, if you can't be smart, you should be lucky. And in this case, we had a little bit of both. But we were extraordinarily fortunate because many of the things the processes that take place inside infected white blood cells are very similar to what happens to neurotransmitters that function between these synapses. And so studying them and realizing that whatever medicine we were going to have to come up with was going to have to be compatible with modern chemotherapy for HIV, this is the part where we got lucky. And that's that when you engineer protease inhibitors, which basically change the face of AIDS therapy, to have better absorption because they don't get into cells very well and they don't get into barrier compartments like the brain, you can increase their half-life and the efficacy, the level of effectiveness of their action in white blood cells. when you add the class of compounds that, and all we were looking for was to make sure that the class of drugs we were trying to develop didn't push us backwards, didn't increase viral load, didn't do anything to the metabolism of chemotherapy. Well, it did, but it did it in a good way. So this is the luck part, where we could increase the half-life of these specially formulated protease inhibitors so that they stayed far longer and they got to far higher levels, to the point where the cell itself, the white cell that was infected, could actually resume its own defenses and digest the virus. So that actually led us to a completely different avenue of research. It still does exactly what it's supposed to do, which is restore relationships between the immune system and the synapses that take care of neurologic function in the brain. But in addition to that, it allows the chemotherapy that targets the virus to get to the point where the cell itself, because it's not dying anymore and releasing virus into the organ or into the interior of any organ, whether it's kidney, lung, or brain, or lymph nodes. Now the cell that is infected by the virus can actually digest the virus. And that gives you the promise of potentially what I would like to say is a chemical vaccine. Not something that gets rid of the virus forever, but something that has the opportunity or the potential to decrease, or rather to increase the amount of time that one could go between chemotherapy. So what I mean by that is a shot that someone might take once a month, once every 3 months. Our target goal is once a year.
Thank you. Thank you.
You're welcome.
So, Amneris, Steve, do you want to add anything more about inflammation in general?
Yes. I think inflammation not only is causing neuroaids and aging, accelerated aging, but cardiovascular disease, which has become very, very important. We right now are conducting a study using a new statin that doesn't have to go to the P450 system, so there's no interactions with the HIV medications, in patients who have very low cardiovascular risk, and observe them over many months to see if this statin will be able to ameliorate the inflammation that is ongoing. Inflammation has also been blamed for many other things, including the fat redistribution, including the increase in lipids that also drives the cardiovascular disease risk. And we see in our patients a lot of frailty, secondary to central obesity. We also see a lot of bone disease, not necessarily exclusively the result of inflammation, but the result of antiretroviral toxicity. And this is occupying a lot of our time in terms of trying to keep our patients with healthy bones, less frail, and also to protect their kidneys, because that's another toxicity from antiretroviral medications. I wanted to add to Handy's comments on the protease inhibitor, how they change the face of AIDS. We now have a new kid on the block, the integrase inhibitors that are coming in with a bang, and they have a better side effect profile that the protease inhibitors did, and have revolutionized what we do in many different ways. And one of the interesting aspects of some of the integrase inhibitors is the fact that the latest one, at least, doesn't seem to elicit resistance necessarily. So those are compounds to look into, maybe in combination with your other compounds that you're using, because there may be another strike of luck, maybe.
Absolutely. I think hard to answer a question with a tangent, but one of the things, this whole notion of inflammation and aging and immunosenescence and sort of that loss of plasticity for the macrophage, for the white cell that is the source, or that ends up being a very significant reservoir of HIV infection in organs, is not just germane to the brain. It's germane to the blood vessels, sorry, I'm apologizing to the microphone, but to the blood vessels, to the heart, to the kidneys, and in bringing to life this class of medicines, we started asking whether this was a general principle between a target cell and an immune cell, and it appears to be the same thing that happens in the heart and the blood vessels, where if you injure a heart muscle cell, a cardiomyocyte, the cardiac fibroblast is normally a supporting cell for it, but once that heart muscle cell is injured, the cardiac fibroblast assumes a pro-inflammatory phenotype and starts recruiting other pro-inflammatory white blood cells into the heart. We don't have to talk about AIDS. We can talk about heart failure and heart attacks and things like that. This class of compounds changes the balance between that and is actually to shift the balance back to a more nutritive and homeostatic phenotype, so that we're only talking about mice, but mice that have been given heart failure, you can reverse this. So I am, and parenthetically, people that have heart failure also have kidney damage. They go hand in hand. Those mice that have been given heart failure, their kidneys get better too. So I think we're extraordinarily fortunate to maybe be staring at something that gives us a better window in how the immune system responds to end organ damage, whether it's the brain, the heart, the kidney, or what have you. And we're hopeful that out of all of this, we'll at least have the potential for a different class of therapies. Doesn't work like a non-steroidal, doesn't work like a steroid, and we're hoping will not be immunosuppressive in a bad way, but a good way.
Very
So let's take some audience input. We have a handheld microphone, and someone will run it up to you.
I have two related questions. Is HIV found in any other mammal as an infective agent, or does any mammal keep HIV but not get infected?
Is there another question?
Yeah, and do you have any humans who are immune to HIV?
Those are great questions. So one of the things that actually came up, a couple of us were on Evan Dawson's show on XXI at lunchtime, and so that actually came up, the issue of animals with related viruses. And it turns out to be quite a complicated story, but suffice to say that there are multiple times in history, relatively recent history, meaning the last 100 years, give or take, where it appears that a virus has moved from a ape or a primate into humans. So that happened at least 4 times to give rise to different lineages of HIV. So at least twice from chimpanzees and apparently at least twice from gorillas. And in addition, there's a second virus, HIV-2, that's found in West Africa, and that comes from a Sudi-Mangabe monkey. The Sudi-Mangabe is an interesting example because that native virus in its native host doesn't cause disease. So the two, one might imagine, have co-evolved over time. Very different than when that virus gets into human beings, where it causes eventually AIDS-like illness, HIV-2. So those viruses are examples of zoonoses. In other words, it's an animal virus that entered a human population, and the outcome of that is oftentimes severe disease in the new host because the virus isn't calibrated, if you want, to that new host species. So those are compelling examples of things that we can learn. You know, why is it that the Sudi-Mangabe doesn't become sick? Makes it an interesting question that has a very great deal of relevance to folks living with HIV. And then your other question about are there people resistant? There are examples of genetic mutations that confer a resistance to infection by HIV, and the best example of that is a mutation in a gene called CCR5. So the CCR5, there's a mutation that can occur in that gene where there's a deletion of some amino acid residues, And the upshot of that is that you don't, in fact, make that protein. It's unstable and it's lost from the cell surface. And it renders the cell unable to be infected by viruses that use that co-receptor, which turn out to be the most common viruses involved in sexual transmission. Those individuals are quite rare, but they tell us a lot about how the disease or the virus works. And they also, as it turns out, Timothy Ray Brown, the example of, he is the poster boy, if you want, for the notion that we could cure HIV. He's somebody who was infected by HIV and is now no longer infected. And he had a very involved course of clinical care relating to a tumor he developed. He had a couple of bone marrow transplants. But the important point was that those bone marrow transplants were from somebody who had a mutation in that gene, CCR5. And one of the reasons he's no longer infected is very probably because of that. There are other reasons too, so it's a complicated story, but very relevant to your question.
So let's take another audience question. All the way in the back.
Do you see any application of your research to other autoimmune diseases where immune deficiency is an issue such as multiple?
That's a great question. I'm going to maybe let Andy take that question. So the question for those of you who perhaps didn't hear it is, and I'm going to broaden your question if that's okay, to really sort of address the issue of have we learned things from HIV that have application to other diseases? And there are a number of very good examples. One is obviously hepatitis C. We have incredibly effective drugs against hep C, and those are all premised on what we learned from HIV. We learned how to make protease inhibitors. Many of those were derived in partnership between academia and industry. They were based on NIH-funded research out of academic labs, and it was developed by industry, and they've led us to these really effective drugs for hep C. But Andy can tell you also about stuff he's doing that relates to an animal model, for example, of multiple sclerosis.
So one of the things as a clinical neurologist that so fascinated me about HIV was that it was truly something that could touch virtually every organ system and pretty much every disease, every neurologic disease that you could imagine under the sun. And in terms of thinking that some of the proteins that are elaborated by the HIV virus, one of the ways that they cause this persistent and almost self-amplifying inflammation, at least in the brain, would be to raise the question of whether you were dealing with an autoimmune phenomena. So that made us curious about whether this general class of compounds that we had been working on would also be effective for other diseases that are thought to have an autoimmune etiology. And multiple sclerosis is one of them. So using a model called experimental autoimmune encephalomyelitis, lots of polysyllabic big words, but you essentially immunize a rodent against a protein found in the white matter. That's the insulation along the axons, the wire from the nerve cell. And that's what actually everybody thought multiple sclerosis was really about. And of course, everybody sees the motor and the sensory troubles associated with it. But one of my former Ph.D. students, who's also a neurologist as well, became very interested in caring for folks with MS. And the thing that he noticed about this was that it wasn't the white matter symptoms that they were complaining about, not the walking with a cane, not the fuzzy vision or the impaired balance. It was the fact that they couldn't remember things, they couldn't balance their checkbook. They really were struggling with loss of their independence. And as people looked more and more at this, they saw that many of the same issues that were raised when I touched upon HIV-associated neurocognitive disorders were also there in MS. And they were far more troubling. And as a sidebar, all of the immunomodulatory drugs for MS didn't touch these symptoms. They might help with the motor systems, they might help or with the motor deficits, the sensory problems, but they weren't touching the cognitive impairment. So in this model of MS, he started to look at the place in the brain where we first start to consolidate memories, and that's the hippocampus. And sure enough, it looked exactly the same as in models for HIV. And same cytokines, same trouble with the synapses. And when he gave this drug, and parenthetically at half the dose that I had originally hoped he was going to be able to give it to, the animals looked like they had absolutely no disease at all. The inflammation that we would see in the hippocampus was gone, and the synapses looked normal. So it was good enough evidence for the NIH to actually give us something called an SBIR to test this versus a different class of compounds in what's called an accelerated phase 2, with the idea that if the results were promising, we would gear up for clinical trials for MS. So I think the answer is a cautious yes, that this might be really broadly applicable to those types of problems.
I can apply, with HIV vaccine development, because it's been so difficult of a problem, so much variability, some of the approaches that we've had to take because we didn't get a simple vaccine with our first try is now kind of coming through influenza vaccines, trying to make a global flu vaccine you don't have to get every year, that sort of thing. So almost in all areas, and it's because there's been a lot of focus on HIV, a lot of money going into the whole it affects the entire body. And it does turn out that a lot of these problems with host and infectious agent are similar in certain ways. So a very lot of spin-offs have already happened and
even the
continue.
molecular technology, viral load, and all those things
Right.
that we never had for other diseases. And because of HIV, now it's applicable to a lot of infectious diseases.
Right.
So
Let me jump in
that's
real
global
quick. I'm
field.
sorry, please. Jump in real quick and ask the panel, especially Dr. Dewhurst, what are the prospects for a cure of HIV?
So as I sort of alluded to, Timothy Ray Brown's personal odyssey towards his cure was a complicated odyssey. He had a couple of bone marrow transplants, he had immune suppressive therapy, he had transplanted cells that were resistant to the virus. So really what we want to do from that is learn what parts of that can we replicate in a way that is much safer and applicable to a larger group of people. And maybe by way of getting a little bit at the question Michael's asking, I'm going to call on somebody in the audience. He's one of our young faculty members. He really works in this research area. He's conducting research that relates directly to a cure, to understanding host factors that control the virus. So Jean Zhu is an assistant professor in microbiology, and I wonder maybe if Jean, you could just speak just briefly to the kind of work you're doing and why it's exciting and important.
Okay, thanks, Steve. Yeah, so I'm a young faculty junior faculty, I won't say young, junior faculty in University of Rochester. So I just started career about 2 years ago here. So our lab very enthusiastic to find the strategy trying to target those residual virus in AIDS patients that under the heart treatment. So you guys probably know that the heart is very potent to constantly keep the virus under, suppress virus from the active replication. But unfortunately, these drugs are unable to eliminate residual virus from the body. So the AIDS patient have to use this drug for life, and it associated with a lot of cytotoxicity and other significant side effects. So basically, our lab trying to find the small compound as a new drug can eliminate this latent virus from the AIDS patient. So our preliminary study does find some few promising chemical reagent that we hopefully can test them first in the test tubes, and then we can move to the real AIDS patients. Thanks.
So, thank you. So the idea basically is to somehow activate latent virus that's hiding and sort of flush it out. Is that part of it? Yeah. Yes.
Basically, you treat the virus by reactivate them, and then immune system that can recognize those. The immune system basically they have two different kind of cues. One called a functional cue, the other called sterilizing cue. So the sterilizing cue, basically, like Michael mentioned, is we trying to target those latent residual virus. We wake them up, and then the immune system now can recognize them and they eliminate from the body. And the other kind of cue called a functional cue. Basically, we're trying to keep the virus to a permanent sleep. So even without a heart treatment, and this latent virus cannot be reactive anymore. So there's different approaches, but the goal is trying to, to kind of keep a virus under control in the latent stage, and the AIDS patient doesn't need to use antiviral drug anymore.
Thanks so much. So we can take that question in the back now.
Hi, David Miller with the AIDS Treatment Activist Network. And unfortunately for Tony Fauci's peace of mind, there are still some of us doing that. And I have two questions for the panel that are co-related. Why isn't the discussion of the morbid declines that we're seeing in study section being presented, both in the general media and at the HIV conferences? So we've seen a drop in grants that are going through study section for the basic science, for what's going to go on in the benches to discover new premises for eliminating the virus, for flushing the sanctuary regions, for activating ApoBec3G, declined 80% during the 8 years of the Obama administration. Now, NIH still has funding, but this keeps on going down and withering the scientific integrity that we need from young scientists, and it still doesn't get discussed. And so that's the first question. The second question for Dr. Gottlieb and the rest of the panelists, how does the community start restraining, and this isn't directed towards any of you, but some suggestions about how we start restraining the key opinion leaders who, in the stampede towards the cure, keep on declaring victory while we've still got a body count of unprecedented proportions rising towards the horizon. We've got tens of millions of people who have absolutely no hope of being treated for PCP pneumonia, for Kaposi sarcoma, and PEPFAR is never going to reach $200 billion to reach those folks. So while we've got Oyogen right here at the University of Rochester working on ApoBec3G modulation and VIP dimerization antagonism, and we've got a perfectly good nucleoside analog at aprocitidine rotting while salvage therapy patients desperately need it, we have no momentum from the key opinion leaders we've always depended on. We just don't see that emphasis, like the AIDS crisis went away. And I'd just like to remind you one last thing. In 1996, David Ho said, we've got 5 years to a cure. I was there in Vancouver. So were you. So were you. Fourth row. Number two. In 1992, Jonas Salk, who had a good acumen, he kind of cured polio and a Nobel, said we'd have a cure. We have this impetus going on from Visconti, from Tim, and from the Boston patients, and every time a new breakthrough comes out, the general media screams, they're cured. How do we stop that once and for all? Because the IS declaration in Australia didn't do the job. Thank you.
Thank you.
I could comment that, with the NIH funding, I think we're all activists. I'm glad you brought that up because it is a big problem. And another interesting thing, thinking about today, if society thinks we're going to be able to make this all with pharma, well, where do the investigators from pharma come from? They come from academia. And if there's no grants to train these people, so I said earlier today, I could easily see doubling the NIH budget instead of cutting it, and the value added, the payback, because really everybody is pretty interested in better health and the things that can be learned through NIH research and other types of research.
So what exactly is the situation with regard to NIH? I mean, funding scores are increasingly competitive?
As many of you probably know, in real terms, the NIH budget has declined something like 25%. over the last decade. When they're having incremental additions to the budget, they've been far below the rate of scientific inflation, and that's really what's eroded our support for all kinds of research, but that includes HIV/AIDS research. What's happened is that the pay lines at many of these institutes, that is the percentage of grants that are funded, is much less than 10%. So it means you can write 10 grants in the hope that one gets funded, and the consequence of that is that young investigators can spend their whole time writing grants and not doing science. The same, of course, true for established investigators. That's a problem. We're not going to make a discovery if we spend our entire time writing grants. There's many people in this room extremely familiar with that and very frustrated by it. There are also examples of people who manage to still be competitive despite that environment. John is a great example of that. He got 3 grants funded in the last year, so hats off to him. James Crowley sitting next to him. James got 2 funded in the last year. So there are people who are able to succeed despite that hostile environment, but what it takes to support them is a strong mentoring structure, it's a strong scientific environment, it's a place where they're able to succeed, which is one of the things that we hope to be able to do, and that's part of the role of the CFAR here. But it's still absolutely true that if we don't increase NIH funding in aggregate, that will remain a huge problem for the field.
And I can say in answer to your question that we can advocate for increased NIH funding. We can talk to our legislators for increased NIH funding, and specifically for HIV/AIDS. And I think that's something the community of researchers and the community who is activist can ask for and push for. And there's also room for philanthropic funding as well to help these guys, temporarily, hopefully, until NIH funding picks up. But in answer to your other question, and I'm not sure I'm interpreting it correctly, but we've got millions of people around the world who can't access the most basic HIV medication. At the same time, we're investing in cure strategies, and we're hearing various investigators issue press releases about little advances, perhaps some of them are significant, but advances toward cure with little blips of virus increased by interventions. And so that gives the impression, I think what you're saying, the impression that we're on top of it, that HIV is managed here, that we're on track for a cure, and it leads people to forget about the many people around the world who can't access the most basic HIV medication. So that kind of gets around to what, and I know time is gone here, but what should we be emphasizing? Should we be looking more toward HIV vaccine in terms of a pot of money? Should we be investing more in HIV vaccine than cure? Or more in cure than HIV vaccine? Or we don't have to make a choice, because cure research is likely to lead to really important developments and interesting things and spin-off. But at the same time, we have to think about people around the world who are suffering for lack of basic medication that we're enjoying the benefits of here.
Just one piece to that, Mike.
Yeah.
So I understand what time.
That's cool, yeah.
Dr. Hooter, the clinician who cured Tim Roy Brown, the only person who has definitively been purged of HIV in every sanitary region throughout his body, had 3 R01s denied by NIH in the past 2 years. 3, and we're still waiting for him to be allowed to speak at the World AIDS Conference or IS. Imagine the World AIDS Conference in Durban and the only doctors ever cured, the only patient still can't get a podium.
So, our time is almost up, is that right? Is that right? So, it probably is up. So let me take the opportunity to thank the panelists for their input and thank you for your participation, and wish you a very good night.